like to focus your attention to a bit different topic, and it's GERD complications. As we can see, the complications are one of the issues that are in core diagnosis of gastroesophageal reflux disease, and the complications may be caused by non-treated or non-optimally treated GERD due to patients or the doctor reasons, and also in patients under standard care that are refractory to this treatment. As a complications of GERD, we can state several forms of problems in esophagus. It is severe esophageal injury, peptic strictures, the most popular complication, Barrett's esophagus, and a subsequent esophageal adenocarcinoma. And in a bit different view on complications, we can count also extraesophageal presentation as one of complications, and also complications of GERD therapy, either medical long-term acid inhibitory treatment or surgical long-term complication of fundoplication. The severe esophageal injury is probably the basis of other complications in all these things. It is sometimes source of important GI bleeding, and probably the relativity range of this source of bleeding is increasing during last 20 years. But it may be more relative to the decreasing reasons from other causes. But it is also one of important things for gastroenterologists in acute GI bleeding. In such situation, prolonged and high-dose PPI treatment is usually recommended. We should repeat endoscopy after 2 or 3 months to detect mucosal healing and to obtain precise detection of Barrett's esophagus, because when we start the biopsy in case of severe esophagitis, it is with many troubles and many confusing factors for the pathologist and also for the endoscopist view. In patients with severe esophageal injury, long-term maintenance therapy is often needed. We should consider our management on patients' compliance and some lifestyle modification. And one of other possibilities in such patient is to consider anti-reflux surgery, but it is not a general approach. Peptic strictures. Peptic strictures are most common benign esophageal strictures, and this is due to fibrous tissue formation, usually on the border between tubular and squamous epithelium. It may be in the cardia, in the esophagogastric junction, in most of patients, but in patients with longer Barrett's esophagus, the stricture may be located in the upper part of esophagus on the border between metaplastic and squamous epithelium. We can see different regional prevalence of peptic strictures in several countries, with probably decreasing counts in last years, and as I found in Russia it is quite high, about 4%, to the lower numbers in different countries. I think, in my personal view, that peptic strictures are a problem of non-compliant patient, of elderly patient with them and Barrett's esophagus, and in most of them the strictures are recurrent. There are standard methods how to treat such strictures, either balloon or bougie dilatation. I think it's more depend on the rules on each hospital or endoscopist. It is necessary part of such treatment, concomitant high-dose PPI therapy. Local corticosteroid injection are recommended by some authors to decrease the incidence of recurrent strictures, but it is not valid generally. but self-expanding removable stents that were designed to decrease the incidence of recurrence and to prolong the efficacy showed non-optimal results now. So in most of our patients with peptic strictures are from time to time recurrent dilatation procedures required. Back to the most popular and famous complication of reflux disease, it's Barrett's. It's defined by replacement of normal squamous epithelium by specialized intestinal metaplasia, and it may be detected in up to 10 to 15% of patients with chronic GERD symptoms, longer a bit less. The main risk factor for detection of Barrett's esophagus is the age at onset of GERD symptoms independently on the presence of symptoms nowadays. There are other factors like obesity, hiatal hernia, and other so-called civilization problems, but the early age of GERD symptoms in most of patients untreated may be the cause factor. Why? We now expect some increasing incidence of adenocarcinoma in many of countries, and maybe we are somewhere on the breakpoint of this incidence, and it is hardly to guess if we are in the breakpoint to the upper incidence or to decrease due to potent anti-secretory drugs. It's believed, and there are some data that support this theory, that it takes 15 to 30 years period from the onset of Barrett's esophagus to development of symptomatic adenocarcinoma. So it is not rapid, fast process, and it is for many, many years. There are some controversial recommendations whom to screen for Barrett's esophagus. I think the clear risk population are older men with chronic reflux symptoms, obese, smoking, and with some previous history in Barrett and or cancer. But I think it is not the whole group in our reflux patient, and we have a lot of other patients that may suffer from risk of development of Barrett's esophagus. There are no clear, but I think there won't be any clear recommendation in whom to repeat such screening tests. It depends on the availability and the costs and risk and access to upper endoscopy. In my personal view, it may be about 10 or more years period to repeat some screening endoscopy in a well-treated GERD patient to try to find out some signs of Barrett's esophagus. But I know it's not clear. What are our wishes or goals of management of patients with Barrett's esophagus? The first of all, we would like to reduce the risk of development of esophageal adenocarcinoma and to reduce mortality for such cancer. But other goals, and I think they are not less important, are we want to treat dysplasia, to stop the development of cancer, to be a step ahead. We'd like to perform surveillance, and we should perform the surveillance and therapy effectively and safely for such patients. And I think it is another important issue. We don't want to frighten our patients by high risk of cancer. What is the real progression of esophageal adenocarcinoma in background of Barrett? And according to last data, we can say it is only 1 per 300 or 500 patients with Barrett esophagus per year. It is increasing such incidence of cancer with a degree of dysplasia and, according to some sources, with the length of Barrett esophagus. But it is, I think, quite rare, such progression. The main tools in management of Barrett's esophagus, standard and generally recommended tools for management, are 2 branches: anti-reflux therapy and surveillance. There are no strong data or strong evidence to increase or select some particle proton pump inhibitor for the treatment, and it seems that standard dosing may be effective and all the drugs may be equal in this indication. The anti-reflux therapy may be also performed by surgery on by fundoplication, and we are comparing these two modalities. It seems that are equally efficient. Surgery may slightly reduce the risk of development esophageal cancer, but it is not the same as in general population, and the evidence is really mild and slight. Surveillance is the background or is the independent part of our management, and it is independently on the type of anti-reflux therapy. There are some recommended biopsy protocols for biopsies and their time periods. The recent data from the meta-analysis that compare the surgical and medical anti-reflux therapy in patients with GERD show a mild decrease in incidence of cancer in patients treated surgically, but I think it is more retrospective data and this evidence is low, so we can't strongly recommend our patients to prefer anti-reflux surgery to medication with PPI to prevent development of esophageal cancer. We have no data and the evidence is quite low, so we should take the choice for our patients. The management of dysplastic Barrett's and cancer is different. We have many tools from endoscopic therapy, usually endoscopic mucosal resection for any nodularity and irregularities in segment of Barrett's esophagus, ablative therapies for residual segment in dysplastic pressure, and also we can treat superficial cancer endoscopically. Surgery takes place in deeper invasive cancer together with neoadjuvant multimodal oncological therapy. There are several national or international recommendations about the intervals of surveillance in patients. I'd like just to comment it briefly. When we have a new diagnosed patient with Barrett's esophagus, it's recommended to repeat it to confirm the diagnosis within 1 year. And then when there is no signs of dysplasia, we should repeat it every 2 to 5 years, dependent on our own practice. No interventions are generally recommended in patients with Barrett's without dysplasia. In patients with low-grade dysplasia, it is a bit controversial. There are some new data that support interventions. The older recommendation said that surveillance is necessary and optimal approach. I think we can consider both methods together with the patient wishes. And we should confirm the low-grade dysplasia before any intervention. The recent data that support the intervention approach in patients with low-grade dysplasia came from a study on radiofrequency ablation in patients with low-grade dysplasia that showed lower progression of low-grade dysplasia Barrett's to high-grade dysplasia and adenocarcinoma in treated interventional patients. But I think these data are quite new, and the methods like RFA is not available worldwide. On the opposite side, when we have a patient with high-grade dysplasia, it should be treated endoscopically, and surveillance is only minority problem in some polymorbid patients according to their wishes. For the endoscopic tools, we have, I think, quite standard tools for endoscopic mucosal resection, that we should resect all visible abnormalities. It is sometimes more biopsy sampling than definite treatment, but we can obtain accurate staging in patients when we have quite large sample from endoscopic resection, and cap-assisted or ligator-assisted methods seems to be equally effective, and we should take account the risk of stricture formation. Ablative methods, and it's mainly in literature about radiofrequency ablation, referred very encouraging results in last years with elimination of intestinal metaplasia and decreased risk of development of cancer. But in many patients, repeated sessions are needed. We absent the histology samples. We should also count with stricture formation, and I think the biggest problem in many countries are costs of such methods. Other ablative methods like argon plasma coagulation, I think recently with submucosal injection or photodynamic therapy are available only several countries. I think according to all clinical and international recommendations, we can feel some clinical problems in Barrett's esophagus on all reflux complication. One of it may be the intestinal metaplasia in a very short segment of but visible metaplastic mucosa. It is about 1 centimeter or less. In my personal view, it may be recommended in such patient to repeat any endoscopy in 5 years period, and I think it is not so dangerous for patient and for the health system to let such patient in the surveillance scheme. I think, and it is not a problem in my country, I think it is in many countries, the quality of endoscopy and quality of pathological diagnosis is different. I think there are particular differences in availability and costs of therapeutic endoscopy in many countries, endoscopic resection, ablative methods, and others. And I think when we take into account, especially in general view of medicine, the relativity of esophageal cancer burden to colorectal cancer for screening programs. Ladies and gentlemen, let me conclude my topic that GERD therapy may prevent development of Barrett's esophagus and other complications. Guidelines recommend us surveillance intervals and interventions. I think the most important issues in recent guidelines are to consider endoscopic intervention, low-grade dysplasia, but it is not necessary, but high-grade dysplasia should be treated endoscopically worldwide. And new therapeutic methods make evolution in approach to patients with Barrett's esophagus, but endoscopic surveillance cannot be omitted. Thank you for your attention. Спасибо за внимание.